Hi there, and welcome back to the Dutch Podcast. I'm Dr. Jacqueline Smeaton, and on this podcast, we dive into the vast and ever-evolving world of hormones as part of our lifelong pursuit of better health. Here at Dutch, we've dedicated over a decade to transforming lives by addressing hormonal imbalances like cycle irregularities, perimenopause, menopause, and more. Our mission is clear: to simplify and advance hormonal health for everyone. On this podcast, I get to bring you cutting-edge insights from our top experts on hormone therapy, menopause, personalized medicine, and more. We're all aimed at making a real difference in your well-being. Your questions and feedback are crucial. They shape our discussions and help us navigate the complexities of hormone health together. Now, as always, please remember the content of this podcast is for educational and informational purposes only, should not be considered medical advice. Be sure to consult your healthcare provider for medical advice, diagnosis, and treatment. On today's show, I get to talk with one of the leading experts on menopausal hormone replacement therapy, Dr. Tori Hudson. Now, I initially learned about menopausal hormone replacement therapy from Dr. Hudson, and she's been teaching about menopause for literally decades. If you talk with integrative providers in the space, many come to her to learn that initial approach. What I love about Dr. Tori's approach is she's evidence-based, she cuts to the chase, and she tells it like it is. And sometimes will tell us things that are not necessarily what we expect or what we want to hear, but definitely what is coming from the evidence. On today's show, we're going to talk all about menopausal hormone therapy, who it's best for, how to determine whether it's right for you or for your patient, what the main symptoms are, some natural approaches that you could consider on top of or before moving to hormone replacement therapy. And we're going to talk a lot about the data. Why is HRT getting a resurgence? Why did it used to have a bad rep? And what is the truth about it all? Let me tell you a little bit more about Dr. Hudson. Now, Dr. Tori Hudson graduated from the National University of Natural Medicine in 1984, and she served the college in so many different capacities. She's actually been in practice at A Women's Time in Portland, Oregon for more than 40 years, really serving women for all of their healthcare needs. She's also owned and directed product research and education for Vitanica, and she's a program director for the Institute of Women's Health and Integrative Medicine. She has done so much for the world of women's health, and we're really blessed to have her with us today. Thank you so much for being with us, Dr. Hudson. I'm so excited to get the chance to chat with you today.
All righty. Good to see you, Jacqueline.
So really, I first learned about menopausal hormone replacement therapy from you and have long studied under you. So I'm really thrilled to have the chance to talk with you about this topic today, because it's something that certainly Dutch providers care a lot about. And I think more importantly, patients care a lot about when they're not feeling at their best and they're hearing from different providers about different safety concerns and just a variation or a spectrum on whether HRT is the right approach for a woman in peri or postmenopause. So I'd love to just start by understanding, what is it that you hear from a patient that makes you think maybe menopausal hormone replacement therapy is a good option?
Well, that's a great place to start. And first off, menopausal hormone therapy is having a new moment in time here again. It's since 2002. And the Women's Health Initiative, took a big dive, and it's taken kind of over 20 years for it to come back to prominence, I think, in the mind of consumers and patients. Although clinicians who've been paying attention to this research throughout the whole time period, even exceeding the last 22 years, have been very comfortable with the safety and benefits and risk this whole period of time. So what's bringing people in now, what's brought women in always is just they're having some significant quality of life symptom that they think is related to perimenopause or menopause as they understand it. And the most common is moderate to severe vasomotor symptoms or hot flashes and night sweats. But but it doesn't have to be only that, and it doesn't have to be that at all. But that just happens to be the most common, and it disrupts their sleep. And when it disrupts their sleep, then they have tiredness, they have irritability, they have depression, they lose their motivation. So that lack of sleep at night due to vasomotor symptoms is kind of can take their life. But other common things that bring women in that thinking, hey, I think and these are menopause symptoms and I might need hormones and I read about hormones and I want hormones. Could be mood swings, sleep, unrelated to hot flashes at night, fatigue, body aches, low libido, vulvovaginal dryness. That's kind of probably the top tier.
Okay. Now, I know you said like it's undergoing a resurgence after taking a dive in 2002 with WHI. Can you just speak a little bit for people who might not be familiar? What caused it to take a dive back then?
Yeah. Well, there had been a few decades where menopausal hormone therapy was sort of the be-all, the end-all for women kind of in their 50s. And it was routinely recommended whether you had symptoms or not. But the chief motivating factor for the clinician is to reduce a woman's risk of cardiovascular disease. That was the driving force. And then the WHI in 2002, which was the largest randomized controlled trial ever done on menopausal hormone therapy in women, and probably will always be the largest ever done, said, well, this thing that we've been doing for the last 40, 50 years is not really true. And that several decades of research on cardiovascular disease was almost all observational studies. So it was like, and then there was a couple, the HERS study was the first one that sort of raised some concern about clotting in the first year. And then the WHI said, it's not reducing the risk of women's heart disease at all. In fact, it's increasing it, and stroke and DVTs and cardiovascular disease in general. And that was the thing that really shifted the prescribing of preventing heart disease to now actually increasing heart disease. But the thing that really freaked everybody out was the breast cancer and the increased risk of breast cancer. The things that was the problem with those two media conclusions and even practitioner conclusions was the women were older. These were women who were initiated hormone therapy in their mid-60s. And now we have these last 20 plus years to really understand, if you initiate menopausal systemic estrogen therapy with or without the progestogen in a woman more than 60 years old or more than 10 years after her last menstrual period, that's what will increase the risk of cardiovascular disease. And that's because your arteries are older, there's more plaque, there's less elasticity, inflammation markers, etc. The other thing, the study was stopped at 5.7 years after starting because it just barely exceeded the safety factors for breast cancer in particular. And everybody said, oh my God, it's a 1.29 increased risk of breast cancer. But again, the people who were really the smart interpreters of research of this kind that I was fortunate to be able to learn from is that that risks actually was rare. And when they reanalyzed and everything, it was only in the women who were had taken menopausal hormone therapy at some other time, not the naive, first timers, did not increase the risk of breast cancer. And that 1.29 turns out is not quite one more woman after 1,000 women annually after about the end of year 3. So between year 3 and year 4, if you're on estrogen and the progestogen, not quite one more woman out of 1,000 would get a breast cancer. And then it went on to say that estrogen only didn't increase it at all.
Yeah, I mean, that's so interesting. I know when we look at like the 1 in 1,000 more, if we compare that to other risk factors like drinking alcohol, it's the risk of, I don't know what the statistics are, you might know off the top of your head, but so many other lifestyle choices have a much bigger impact on breast cancer risk compared to MHRT.
I love that little factoid. When I read that, I was like, oh my God, if you put this in perspective, okay, not even one more woman out of 1,000. That's also tiny, tiny, and tiny. But if you put it in perspective, that is a risk only slightly greater than one daily glass of wine, and it's less than 2 daily glasses of wine, and it's similar to the risk reported with obesity and low exercise. So I think that I tell patients that, I mean, first of all, when you say that not quite 1 out of 1,000, pretty much everybody relaxes. You don't want anybody to be that one person. Up until very recently, I would say, again, because of the sort of having a moment thing, women, when I would recommend menopausal hormone therapy for certain reasons, they would need a lot of reassurance about the breast cancer. But now they need, women are coming in and they're 65 and they're 70 and they want to start, and they've never been on. And so now we have to say, well, actually, that's not a good idea. And we go through the reasons for that. But women now are like eager, bone, brain. And I think the brain thing is really gonna, in the next 10 years, probably even shorter, it's just gonna, I think the menopause hormone, I predict that that we will be recommending that we will be recommending more eagerly systemic menopausal hormone therapy within the first 5 years, especially of their last menstrual period, to reduce a woman's risk of Alzheimer's.
I love that you bring that up, because the data right now is not clear, or, when it comes to bone health, there's clear data. Hormones protect the bones. When it comes to symptom management, there's clear data, from vasomotor symptoms to genitourinary symptoms. Hormone replacement therapy is helpful. With cognitive symptoms, I think clinicians see it. Patients report to us how they feel so much better, but there's not the literature base yet to confirm that. But I love hearing you say that you think that we're moving in that direction based upon what you see.
Yeah, I based on what I see and research, like Dr. Lisa Mosconi, she's to me like, kind of the leader of the charge. How I interpret the data at the moment is, if a woman has no ovaries and it's been prior to 10 years since she had her ovaries, or she's less than age 60, I will recommend that she go on systemic estrogen. Because her risk of Alzheimer's dementia is higher without her ovaries and without estrogen. I also recommend it as I'm eager to recommend it for women who have a first-degree relative with Alzheimer's dementia, and if she's less than 60, or within the first 10 years. Those two things are really important in Alzheimer's, in particular, risk reduction, because there's a decent amount of data that if you start later, and this is why I have to redo these things that women are reading and listening to right now. They're coming in at 70. Oh, I want to protect my brain. Well, actually, no. If you start after 60 or after 10 years past your last menstrual period, it can actually likely increase the risk of Alzheimer's dementia. So that's a really important thing for the brain deal.
That's awesome. Now, another thing that was interesting with WHI is the forms of hormones used in the study were primarily oral conjugated equine estrogen, or CEE, and then medroxyprogesterone acetate, which is a synthetic progestin. So do you think that also impacted the studies? Because when we look at what's used in integrative clinics, you're more likely to find bioidentical hormone use compared to synthetic. What do you think about that change? And I ask you, because I think listeners should know you're not dogmatic about decisions for patients. And I really appreciate that about you. If it's a medication option, but that's the best option, or it's even an intervention option, that's the best option, that's not quote unquote naturopathic. If it's best for the patient, you consider it and you definitely pitch it to the patient. So I ask that, are bioidentical hormones an improvement? Are they better? Are they safer? Or is that just us tooting our own horns?
I think there is a decent amount of unfair bias there. You have to parse it out. So let's take the estrogens for a moment. In terms of breast cancer, bioidentical estradiol, Premarin, either of those alone doesn't seem to increase the risk of breast cancer. So there is no advantage there in my mind. Either of them with a progestin, there doesn't seem to be an advantage either. I mean, again, the worst case scenario is one more woman out of 1,000. So why are we, it's like blaming Premarin for, something that's not even, and it's not even reaching statistical significance, and it's not even affecting, even estrogen and progestin doesn't affect mortality related to breast cancer. It's just slight increased risk of incidence. So estradiol, Premarin, there's really no good data that says any difference in the brain. In the breast, there's a very, very slight possible lower stroke risk with estradiol versus Premarin. And there's a very, very slight trend towards maybe a more anxiolytic effect with bioidentical estradiol, like a little friendlier that way. So that's sort of the estrogen story in a nutshell. Cardiovascular doesn't seem to matter. Stroke, VTE doesn't seem to matter if the doses are, equivalent and the delivery is equivalent. The progestogens are a little bit more interesting, especially in the breast. There's now 3 French studies and 1 recent UK study. I don't count the KEEPS trial because it was too short. It was only 4 years. But all 4 of those, bioidentical estradiol with the estrogen, did not increase the risk of breast cancer at all. And again,
do you mean progesterone? Progesterone.
Did I say it wrong? Yeah. Bioidentical progesterone
okay.
with the bioidentical estradiol in most cases did not increase the risk of breast cancer. These are observational studies. And then this progestin, the Provera or something else, synthetic, with the bioidentical estradiol only slightly. This usually about the same, this one more woman out of 1,000. So it really kind of, for the breast, that there does seem to be, I use the word more breast-friendly effect with the progesterone than the progestin. But it's, again, we are going to maybe go from 1 out of 1,000 to 0. Yay. But those are observational studies, not that randomized controlled trial. But I do think it's enough to be the rationale for why we pick bioidentical progesterone over progestin.
Is there any reason or any circumstance? And I mean, this is a loaded question, I guess, but I don't mean it to be. Sorry about that.
No.
Is there ever a situation where you'd choose a synthetic progestin?
There are.
Or is it like insurance coverage or something else, or is there a medical purpose?
Not for me. Insurance coverage doesn't seem to matter, really. Sometimes a plan, like although they're getting more loosey-goosey, I think, but Kaiser system sometimes is stingier with the bioidentical progesterone because it costs them more money. But I haven't really found in general insurance plans that to be an obstacle. I haven't really had to have pre-authorizations for progesterone over progestin. But the why for a synthetic, number one is sort of nuisance effects of bioidentical progesterone, and especially the oral form. And there's that small percentage of women that are going to get dizzy, lightheaded, moody, feel hungover in the morning, and they don't feel that way with the progestin.
Oh, that's interesting.
Perhaps,
because I always moved to a vaginal progesterone in that circumstance, but I had never really thought about a synthetic progestin. I always just assumed it would have the same effect.
It could, but not, I would say, the minority of the time.
Oh, that's cool.
And then the other situation is, even in our proven doses of bioidentical progesterone, and I know you and I are, on a little bit of a mission about that to make sure people are delivering the right amount and the right delivery form of bioidentical progesterone to oppose the estrogen and the nutrient. Even if you do that, the 100 milligrams a day, every day, or the 200 milligrams 12 days out of the month with the bioidentical progesterone, some women will just, that progestogenic effect is just not strong enough to overcome even an average dose of estrogen. So they have breakthrough bleeding. And so those cases, rather than, you could go up in dose, but then again, with the progesterone, but again, you might run into more nuisance effects with that. So that's a time when I would use a synthetic progesterone possibly.
I'm glad I asked that question because I learned something. Thank you. It's fabulous. So you've mentioned a couple things that I want to break down a little bit more. One is forms. You just mentioned it with progesterone forms. And I think what you're referring to is that some providers utilize progesterone cream, thinking that it will provide endometrial protection. I would like to just highlight that that's maybe one of the myths
that
of HRT.
That is indeed, I think, a integrated medicine, functional medicine myth. And despite what is available to read that is based on the scientific publications on this issue, practitioners are still doing it because they think otherwise.
Well, someone told them to, right? I think
someone say there are, you're right. There's trainings and podcasts and things, or some other entity that's promoting that. But there are, to my count, there are 5 studies on this issue. And we do break that down and when we did the webinar on this topic for you all. And so if we go to those, and I must just look at them again, there's, like I said, there's 5 to my count. And 2 of the studies by the same author, one of them was only 28 days. Well, right there, like, that tells me nothing about endometrial protection. And the other second study by that same author was only 6 months, where they used 40 milligrams of the cream continuously. Again, 6 months, that tells me nothing. And even in that 6 months, 19% of the women had a proliferative endometrium with that dose of progesterone cream, which is kind of the usual that you see prescribers doing. So even with that, along with the systemic estrogen, 19% of them had, 2 out of 10. There was no hyperplasia on the biopsy. And then but still, over time, that proliferative endometrium can easily become problematic, 3, 5, 10 years down the road. And then the remaining 3 studies showed there was, in fact, proliferative endometrium, a couple cases of complex hyperplasia, no endometrial cancers, okay, but even these were, I think, like 3 months, and maybe one was 48 weeks, so almost a year. And still, I would say that's not long enough. You need, I would say, 3 to 5 years, and even the IUD studies aren't long enough yet either. So any progesterone cream study, the study was way too small. It was way too short. And there were cases of concern showing proliferative endometrium and complex hyperplasia. So don't do it.
Don't do it. We agree. I mean, I think we take a really similar approach, that kind of evidence-based approach. And the evidence is pretty clear here that a stronger oral progesterone is really necessary to protect the endometrium. Or, there might be other ways, like a progesterone secreting IUD, like you mentioned. That's not enough research to support, but possible. So I want to step it back a bit, because our listeners are probably a lot of providers, but also probably some patients. So I should have started with this question, but framing it up, we're talking about estrogen and we're talking about progesterone for hormone replacement therapy. From a conventional point of view, really estrogen is the therapeutic and progesterone is added. If you're looking at this from like the NAMS point of view, North American Menopause Society, progesterone is there really to protect the uterus from becoming cancerous, because if you have estrogen and it's unopposed, then you can get thickening of the lining of your uterus. The progesterone can stop that over thickening. Am I summarizing that well?
Yeah.
And so the interesting thing is that I think in integrative medicine, we consider benefits of progesterone as well. And there are some studies on progesterone in postmenopausal females. When you think about it, do you think about it from that same point of view? Estrogen's the primary therapeutic, or do you find that, let's say for women without a uterus, where progesterone's not a requirement, could there be benefits to progesterone therapy still?
I agree that the primary reason to give the progestogen is to oppose endometrium. So if a woman is needing to be on systemic estrogen and she doesn't have a uterus, I don't, and I recommend that we don't just automatically give progesterone or progestin in any dose. And the reason why is those small number 4 observational studies on breast safety and progesterone are just 4 and just observational. So why, meaning it's not maybe convincing enough for me to go overboard and say, yeah, I'm just going to give it in any old circumstance. But then there are, and I definitely would not give progesterone for bone protection. I think that data is enough poo-pooed that we can move on from there.
That's your scientific term, poo-pooed.
That's right. That's right. And yes, progesterone can help with sleep, but so do a lot of herbs and nutraceuticals and habits. Yes, progesterone can maybe help some women with their anxiety, but yes, so does a lot of botanicals and nutraceuticals and self-care. So I don't, progesterone isn't in my top 5 for sleep and anxiety. If here's a little circumstance though, let's say a woman, maybe it's a bit too much, but I want to say it anyway. She's had her uterus removed for some benign reason. Let's say endometriosis. And so now she's perimenopausal, menopausal. She's going on systemic estrogen. If she had severe endometriosis, whether no ovaries removed and or uterus removed, if she had severe endometriosis and now she's on systemic estrogen, I do add a progestogen in that circumstance, even without her ovaries, because of that hopefully suppressing effect of little endometriosis implants that are still there or could be there again and could get a little tweaked by the systemic estrogen. And then, so giving the progesterone or progestin, even without a uterus, I think is a preventive medicine strategy.
That makes a lot of sense. I love it. So if you could kind of wave a magic wand and have patients be prepared as they enter perimenopause to kind of proceed with managing their perimenopause and menopausal symptoms, I would say let's focus more on that later reproductive years into menopause transition. So we're not talking about early perimenopause symptoms. So when we look at like naturopathic medicine, we look at the therapeutic order. And of course, there's a lot of other things that can be helpful for women to manage some of the symptoms of menopause, like hot flashes. So I think it would be remiss to not mention that hormones are not the only option out there, but I'd love you to talk a little bit about maybe your top 3 or 4 recommendations for women in that phase of life that are lifestyle, supplement, nutrient support. And also, if symptoms are well managed, let's say they don't have hot flashes, maybe they don't have vaginal dryness, or they're well managed with your lifestyle suggestions, the naturopathic model would say you could stop there, right? Or I'm curious now with the evidence that's come out, because I learned stop there. I'll just say that. I learned stop there, but that was, I won't say how many years ago, but more than, we'll say between 1 and 2 decades, which feels hard to believe. But would you still, from a prevention standpoint, recommend hormones to most women that don't have any kind of contraindication? So multi-part question. Let's start with.
I think I should figure it out.
Yeah, let's start. Wave your magic wand. Tell your patients if they could get your message.
Bring me back to the top 5 if I forget to come there.
Great.
So I talk to patients about there's 3 buckets of things for us to consider. The first bucket is quality of life. What's quality of life issues are you having? What therapies are options in that bucket? Sleep, mood, dryness, severe hot flashes. So there's the quality of life bucket. And then the second bucket is what diseases are you at increased risk for based on your family history or your medical history? And I'm especially interested in, osteoporosis, Alzheimer's, cardiovascular, breast cancer. And then the third bucket is what diseases do you already have that for which botanicals, nutraceuticals, diet, hormones, other medicines might need to be employed to manage those and help them not get worse over time. So the three buckets. And menopausal hormone therapy has a role in all three of those buckets. Quality of life, for sure, reducing the risk of diseases for which you're increased risk for. That could be, in my mind, especially osteoporosis and Alzheimer's dementia. And then the third bucket, diseases you already have, osteoporosis and estrogen. Osteoporosis is in that bucket. And osteoarthritis is in that bucket as well, in my view, in terms of what estrogen could possibly do. So those three buckets, I think, are important to really keep in mind in figuring out the hierarchy and the strategy and the options. The quality of life bucket, we have strong botanicals, I would say, for vasomotor symptoms, especially mild to moderate. Harder if they're severe. In my top tier there is black cohosh extract, Siberian rhubarb, a special species of maca, even pine bark extract is on that top list, and then it gets maybe some combination that have herbs that have a little bit of data. Let's just put libido out there, because libido is not as strong, is a very significant perimenopause, menopause issue for men and women. And I would say there's no real reliable herb for that. There's maybe a chance with maca. There's a little data on maca, ashwagandha, tribulus, fenugreek, but it's a hard ask. And then we have to get into probably testosterone with estrogen in terms of improving desire. If desire is being affected by dryness and pain and discomfort with sexual activity, then I like to say vulvovaginal estrogen is the magic medicine. So those are
Fabulous.
A few things that I might have answered all your questions in there.
Yeah, no, I think you did. So you talked about the quality of life management, and then you talked about kind of the disease prevention. So it sounds like, tell me if I'm wrong, that even in times where quality of life concerns can be well managed with naturopathic medicine, you still would have the discussion with patients about whether hormones are appropriate in order to prevent disease.
Well, if I hear in the history, my mother broke her hip, or I hear I have no ovaries and I lost my ovaries 3 years ago, or I have my mother has Alzheimer's dementia. Those are the things that really catch my attention.
Mm-hmm. Great. And so I think my last question is, what would you say to patients who are thinking that maybe they want to get on hormone replacement therapy? Like, how should they bring this up to their provider? What should they talk about? Any last tips that you'd give to the patients?
Yeah. Well, it's important to find the provider that knows, and this is a weak spot in medicine. Let's just presume that every clinician is good at something. They have a strong suit. But not every clinician is a good menopause practitioner, whether it's the OBGYN or the family practice doc, internist, or naturopath or functional medicine. They're not, you should not assume that everybody has perimenopause, menopause expertise. So I would vet that out. And you can find, there are various ways to find, to figure out who is qualified and who doesn't have some blinders on. But I think that it requires more education on the part of the patient to kind of sort through that. I would also say, there's some great resources. That my favorite resources for patients is the book Estrogen Matters. I think that is the best current book going on organizing the information in a readable way, especially around bone, brain, heart, and breast, as it relates to systemic hormone therapy. And what else would I say? Well, I have a book that might be helpful to some people called The Menopause Companion, co-authored with the wonderful woman named Sasha Davies. I think, Dutch is a good resource in terms of training practitioners and trying to give them the tools that therefore help most clinicians help patients. I think a compounding pharmacy is a good place for a patient to call and say, who is a prescriber in my area that seems to have menopause expertise and is prescribing compounded menopausal hormones in ways that you think is safe. And I think most compounding pharmacists would pass them on that list.
Awesome. Great recommendations. I do want to just point out, Dr. Tori gave our July webinar. So if you want to learn more, it's on the similar topic, although I think it's really a compelling listen and something that if you're interested in menopausal hormone replacement therapy, you'll definitely check out because she covers the top myths in hormone replacement therapy and menopause. And I will say we saved some nuances for the webinar that we didn't cover here today. So it's worth a separate listen for providers for sure. You can get access to that if you go to DutchTest.com and you can become a provider, click become a provider. And once you're a Dutch customer, you have access to our series of webinars. We also have a menopausal HRT series available on the Dutch blog, which is open to the public for viewing and reading. So Dr. Tori, thank you so much for being here. I always love spending time with you and it's been great. And I always learn a lot and I'm sure our listeners have too. So thank you so much.
I appreciate you as well, Jacqueline. Thanks a lot.
If you're wanting to learn and really expand your expertise in hormones, you're not going to want to miss our podcast. So make sure you tune in each and every week for our new content.